This is an edited video demonstrating the harvest of intercostal nerves as a donor for functioning muscle transfer for finger flexion. The incisions marked are along the axillary fold and going in the inframammary crease and extending onto the medial arm. First step is isolation of the recipient vessels. In this case, it is the thoracodorsal artery and vein. Once the recipient vessels have been isolated, the incision goes along the lower border and the pectoralis major is raised as a flap along with the skin. Perforators from the intercostal to the pectoralis major are carefully identified and clipped. This is extremely important because bleeding can be profuse in the postoperative period. Once the entire pectoralis major is lifted up, we see the pectoralis minor, and on the medial side of the pectoralis minor we see the thoracoacromial vessels. In order to expose the entire rib, we need to divide the medial pectoralis minor. The markings are now showing the ribs 3, 4 and 5. First rib, which is palpable under the clavicle, is the second rib. So here we have isolated the 3, 4, 5. Now the hemostat goes and shows the thoracoacromial vessels. That's our donor pedicle, and the pectoralis minor insertion onto the coracoid process, and that's a thoracodorsal nerve. In this case, we can't use it as it is a global brachial plexus. This picture shows the levels of dissection. So first we start with the bovie and divide the periosteum on the respective rib 3, 4 and 5. Along the lateral border of this dissection, part of the pectoralis minor is being divided. The dissection goes up to the insertion of the slips of serratus. So that is our lateral extent. Once we put the incision with the bovie on the rib, we then use a periosteal elevator and raise the periosteum along the lower margin of the rib. So the periosteal elevator carefully reflects off the periosteum from the rib so that we can go all along the lower margin of the rib. The intercostal vessels are situated along the respective ribs lower border. So we start as seen here along the 5th rib lower border. Once we dissect the periosteum of the rib, now we start seeing the lower border and the posterior surface of the rib. The rib is gently reflected upwards and the periosteum is reflected downwards. Under the periosteum we will find the intercostal nerve. Dissection along the posterior margin has to be very gentle but extensive so that the entire rib is freed of the soft tissues. This step has to be done carefully in order not to damage the pleura which is just lying under the periosteum. As we go medially, it is more difficult to reflect the periosteum of the costochondral junction. So at this step now we identify the intercostal nerve, which is seen as a white structure under the periosteum. So this is just a zoomed out image showing how we go and lift off the intercostal nerve from the periosteum. So a small incision has been put on the posterior periosteum, and the glistening white structure is the intercostal nerve. It is confirmed by stimulating with a nerve stimulator as seen here, keeping it at a very low 2 milliamperes current. Once it is identified and dissected off, it is held in a silicone loop so as to not keep on handling it every time. So we pass a silicone loop under the intercostal nerve, and then we prefer to clip with a Liga clip instead of attaching a hemostat, which will continuously cause traction. So now the intercostal nerve has been totally freed from the costochondral junction to the lateral border of what we need. Below is the glistening pleura seen. Similar dissection is carried out on the above rib. You can see the lung under the pleura in the dissection. So all three intercostals have now been dissected off completely. We do not divide it till we insert our flap and till we know the requirement. So here, as you see, we can see the nerve, and all three have now been divided and glued to the obturator nerve. This step is carried out after the vascular anastomosis has been done, and as a final step, the glue also is used to make sure that the intercostal nerves are also stuck in their place and don't move. So they are applied on all along the surface of the intercostal nerves, and that is the final inset of the flap and closure of the defect.